Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Now we're going to discuss the management of locally advanced HER2 new positive breast cancer. I have the pleasure of being with Professor Chuck Bogle from University of Miami. Thank you for being here.
Thank you. My pleasure.
Okay, now let's assume a woman has had a breast mass which has been biopsied and actually resected, and the biopsies come back positive for breast cancer, which is HER2 new positive. What happens next for that woman?
What happens next is I say I don't believe it, and because we have a lot of problems with testing. And a lot of times we see the diagnosis made by immunohistochemistry and comes back as 3+ positive, and therefore it's supposed to be considered as positive. However, we know that about 20% and maybe higher of those are not going to be FISH amplified. And so then it becomes a dilemma. And so you have to do some in-depth testing to make absolutely certain you're dealing with a Her2 new positive tumor.
So what if someone does have an IHC plus 3 but FISH negative? Do you consider them HER2 new positive breast cancer?
If the FISH is done in an absolutely reliable lab that I trust, and the IHC is done in an absolutely reliable lab, preferably the same lab, then I will treat the patient as a Her2 new positive patient. That's based on a study that I did a long time ago, where we studied Herceptin, or trastuzumab, which is the generic name. Herceptin is the trade name. And we tested trastuzumab in women with metastatic breast cancer. And we looked at them initially. They were able to go into the study on the basis of IHC, immunohistochemistry. We later went back and we retested all of them by FISH. And we found that almost every one of them, if they were FISH positive, it was only the FISH positive patients who responded. I'm not saying that all FISH positive patients respond. They do not. But it was only the FISH positive patients who responded. And all of these were supposed to be IHC positive. We did find, of those, 3 patients that were said to be 3+ positive and FISH negative. So the pathology referee in that was Michael Press, who is really one of the gurus of Her2 new pathology. And so I asked Mike, I said, go back and tell me why these 3 responded. And he went back, and even though he had done the original FISH himself, he found that 2 of them were actually false negative FISHes in his lab. So then we were down to 1. And we do have a patient who is 3+ positive, FISH negative, a so-called single copy overexpressor, who did respond to trastuzumab. So yes, 3+ positive, FISH negative patients have been described. There are others that have been described in the literature that do respond, so I would treat the patient. But before I do that, I jump through 1,000 hoops to make sure that the testing is absolutely correct.
So, I mean, as far as the patient is concerned, if their doctor in private practice tells them, you're HER2 new negative, should they ask for a second opinion from a different lab, or what should they do with that information?
I would try to get a second opinion from somewhere, from somebody who really knows breast cancer and knows laboratories, and make sure that the testing is done, the repeat testing is done in an absolutely reliable laboratory.
I see. Please explain what a sentinel lymph node biopsy is and what implications does it have if it's positive versus negative?
A sentinel lymph node biopsy was actually started with the disease malignant melanoma. And it was there that some of the dissections, let's say if somebody had the disease in their leg, it would lead to dissection of the lymph nodes in the groin, and that was often very painful, led to massive edema or swelling of the leg. So people got the idea, maybe if we just were able to identify the very first lymph node that drains that tumor, and tested that one, that would be predictive of what the other lymph nodes would be like, and we could avoid a lymph node dissection or total lymph node removal. And so they started to do that in breast cancer, and you can do it. It was initially done using blue dye, and you would inject blue dye around the tumor, and you track where the blue dye went, and then you would remove that node. Now we're more sophisticated. We use radioisotopes. Some people use radioisotopes and blue dye. So you basically run a Geiger counter over the area. You find the lymph node that is the first node draining the tumor. You remove that node and usually one or two nodes around it. And if that node is negative, the likelihood is very, very high that the remaining nodes are also going to be negative. So it is now an accepted practice that if the sentinel lymph node is negative, a lymph node dissection is not done.
I see. Now, what if that lymph node is positive? What happens next?
Well, that gets far more complicated because basically we're in a time warp where we now have a couple of studies that have randomized women who have had positive sentinel nodes to further removal of the rest of the nodes or not. And these studies have not indicated a benefit to the removal of the rest of the nodes. However, these studies are somewhat flawed. One of them was what we call basically underpowered. There weren't enough patients to give a truly statistically significant answer. So the purists are waiting for bigger studies, larger studies, but I can tell you as of right now that Memorial Sloan Kettering has a policy that if the patients fit the criteria of the so-called Z11 study that was done by the ACOSOG cooperative group, if they fit the criteria of the patients that were in that study, and they have a positive sentinel node, they do not do a sentinel node biopsy. I mean, they do not do a complete axillary dissection. So what are some of those criteria? Well, the patient has to have had a lumpectomy and radiation. And the radiation part of it is important because when you irradiate the intact breast, you use tangential fields and they hit the lower axillary nodes. So in essence, you are treating the axilla. And so for those patients who fit those criteria, at Memorial Sloan Kettering, they do not dissect the rest of the nodes.
I see, but I would say in the United States, at least for the most part, a woman will get a full dissection. Would you not agree if the sentinel lymph node is positive?
Yes and no. I would say that there are a number of individuals and practices that are moving in the direction of not dissecting the axilla if the patient meets the ACOSOG Z11 criteria, just as Memorial Sloan Kettering.
Interesting.
And in my practice, I discuss this in great detail with my patients. If the patient fits those criteria, I tell them the pros and cons of the studies, that they are not definitive, but that the wheels seem to be moving in that direction.
I see. So it sounds like, as far as you're concerned, there's either lymph nodes that have spread or there aren't, and that's kind of the two decision trees which will lead you to the treatment, correct?
Well, it's more than that. Making decisions as to when you say treatment, there are many different treatments.
Mm-hmm.
We're talking now about systemic treatment, which would mean either anti-hormonal therapy, cytotoxic chemotherapy, or in the case of Her2 positive disease, the use of trastuzumab as well. And maybe in the future, lapatinib, which is another anti-Her2 drug. So we look at many things, not just the lymph nodes.
Mm-hmm.
So for instance, to make systemic therapeutic decisions, we have something called Oncotype DX,
Mm-hmm.
and another tool called MammaPrint. Oncotype DX is a gene profile that is given to the tumor. The tumor is tested for a number of genes, a total of 21 genes. And those genes then are calculated into a score. And a low score frequently means that the patient has a very low likelihood of needing chemotherapy. So if the patient has negative nodes and positive estrogen receptors, Oncotype DX is indicated. And with Oncotype DX, if the score is low, it really means that there's a low likelihood of response to chemotherapy, or that it's going to add very much. It might add another 1% or 2% to the likelihood of curability. It's not going to, adding chemotherapy is not going to be negative. It still will be positive, but the percent benefit, if the Oncotype score is low, is going to be very low, 1 to 2%.
Mm-hmm.
What Oncotype has done, if you look at some of the studies taking a look at how doctors have used it, doctors have been asked, okay, here's a group of patients. Would you have recommended chemotherapy or not? And they would say yes or no. Then you say, okay, now here's the Oncotype score. Would you recommend chemotherapy or not? And the answer uniformly is that 25% of patients who previously would have received chemotherapy for node-negative disease
Mm-hmm.
Are no longer receiving chemotherapy because of a low Oncotype score. On the flip side of things, maybe 5 to 10% of patients who you had said, oh, I'm not going to treat this patient with chemotherapy, actually were treated with chemotherapy because of the Oncotype score.
Do you check Oncotype for your HER2 positive patients?
No.
Oh, okay.
I don't check it for Her2 positive patients because the way Oncotype is structured, there's some mathematical modeling that's done. And in the mathematical modeling, Her2 is given a very high score.
Mm-hmm.
And so consequently, virtually every Her2 positive patient will turn out to have a high Oncotype score. So for me, it's a waste of time to do Oncotype in a Her2 positive patient.
Yes. So let's look, before we actually get into the specifics of treatment, please explain what staging means to our patient. How do you stage a patient with breast cancer, HER2 positive?
Well, I think before getting into staging, we should complete the Oncotype story.
Okay.
Because we're now looking at Oncotype in node-positive disease.
Mm-hmm.
And I use Oncotype in node-positive disease. And the bottom line here is that if a patient has 1 to 3 positive nodes and a very low Oncotype score, there was a study called the Trans-ATAC study that Mitch Dowsett from the UK presented.
Mm-hmm.
And he presented an algorithm that shows that if you receive hormonal therapy alone and you have 1 to 3 positive nodes
Mm-hmm.
and a low Oncotype score, the results with hormonal therapy alone are very similar to node-negative disease.
Mm-hmm.
So for patients with low Oncotype score and a positive node, I discuss this with them in depth.
Mm-hmm.
And many node-positive patients now are also not getting cytotoxic chemotherapy.
Right, I understand. That's a very good point. But this, the patients watching this video are HER2 positive patients, so that would not necessarily apply to them. I don't want to confuse the patients. Yes.
Okay. Well, that's a different issue.
Mm-hmm.
We were just talking about Oncotype. At first, we were talking
Mm-hmm.
about Oncotype in general.
Right. Exactly.
And so, if we're talking about Oncotype in general, I thought people should know about that.
Sure.
Since I don't do since I don't do Oncotype in HER2 positive patients, it doesn't even apply.
Exactly.
In the node positive, HER2 positive patient.
Very good. So let's talk about the staging now. How do you stage a patient with breast cancer?
Well, the stages are really based, there are 4 stages. Stage 1 is a patient whose tumor is less than 2 centimeters in size,
Mm-hmm.
and the lymph nodes are negative. In essence, stage 2 can either be a patient who has a tumor between 2 and 5 centimeters in size and negative nodes, or a patient of any tumor size
Mm-hmm.
that has some positive nodes. Stage 3 disease tends to be patients with a lot of positive nodes.
Mm-hmm.
And stage 4 disease is distant metastases.
Now, when would you recommend a lumpectomy versus a mastectomy to one of your patients?
Well, I don't ever recommend one or the other. I always give the patient an option, and you become very surprised very quickly when you find people that you think would heed the data. And the data clearly show that a lumpectomy and radiation is equivalent to mastectomy.
Mm-hmm.
However, even with that piece of information, there are many women who opt for mastectomy for whatever reason.
Mm-hmm.
So I don't presuppose and try to interject my own personal view. My own personal view is if one can do a good lumpectomy and leave a woman with a cosmetically acceptable breast with her own breast tissue, I see no reason, given the fact that there is no survival advantage to mastectomy, why one should do a mastectomy.
Mm-hmm.
And the irony is that now that we have this information that lumpectomy and radiation is equivalent to mastectomy, we're seeing more women getting bilateral mastectomies.
Mm-hmm.
Well, why is that? I think one reason is because we're doing probably too many MRIs.
Mm-hmm.
And a common scenario is a woman says, okay, I'm going to have my MRI. I have the MRI. Doctor says, well, we see this cancer, but we also see 2 other things in different parts of this breast. And by the way, we see something else in the other breast. So what we got to do is 3 more biopsies. The woman says, take them off.
Mm-hmm.
So that's the scenario. Another reason is that we have better plastic surgery in this day and age. And so women think that they now have perhaps a better alternative. And in the back of many women's minds, they just sort of think that a mastectomy has got to be a better operation. It just isn't.
Mm-hmm.
There are reasons why women have to have mastectomies. I mean, if there are tumors in 2 different areas of the breast, that's a reason to have a mastectomy.
Mm-hmm.
If the woman has a big tumor in a very small breast, and that tumor cannot be shrunk down by chemotherapy or hormones to where a cosmetically acceptable lumpectomy can be done, that woman would be better served by a mastectomy. A woman who, let's say, has had Hodgkin's disease in the past and has had radiation to that area already, that woman might be better served with a mastectomy because they will not be able to get curative doses of radiation. So I try not to interject my own bias. My own bias is to do a lumpectomy and radiation whenever possible.
Now, what if in a situation where a woman has had the breast lumpectomy and radiation and the lymph nodes are negative in the axilla? Do you recommend adjuvant chemotherapy or trastuzumab in the Her2 positive setting?
In Her2 positive disease, I almost always recommend chemotherapy and trastuzumab. And that means in even very small tumors. But here, one really gets down to the nitty-gritty of the data or lack of data. Virtually everybody agrees that if the tumor is greater than a centimeter in size, the patient should get chemotherapy and trastuzumab. I think most opinion leaders, if the tumor is greater than 0.5 centimeters, will also give chemotherapy and trastuzumab. It's in the patient who has the 0.2, 0.3 micrometastatic focus that the waters get very muddy and the literature gets very muddy. There are studies from MD Anderson and from Milan and a couple of others that indicate that that even for these very small tumors, there is a higher risk of relapse. There's a very good study from Lou Fehrenbacher from the Kaiser Permanente group that indicates that if you have a tumor less than 0.5 centimeters, that their likelihood of developing a distant recurrence is very, very, very low. And I know these data backwards and forwards because I had 3 of these patients in a week. And I had to sit down and go through each and every paper with these women. And I can tell you that 2 of the women, after fully informed consent, did not accept treatment and accepted observation alone.
I see.
We are currently doing a study under the leadership of another of my colleagues, Dr. Eugene Ahn, in collaboration with Cleveland Clinic. No, it's not Cleveland Clinic. It's Case Western Reserve, I'm sorry. Where we're looking at trastuzumab as a single agent in women who either cannot or will not accept chemotherapy plus trastuzumab, but will accept trastuzumab as a single agent. But that would be part of a study. There are some women, I saw a patient the other day in second opinion, who had already made the decision after speaking to her oncologist that while the recommendation would be for chemotherapy and trastuzumab, she refused chemotherapy and would only accept single agent trastuzumab. Until we have answers from clinical trials, we don't know whether that how effective an option that would be.
So let's say the tumor is more than a centimeter and you do opt for chemotherapy and trastuzumab. Please explain how that works. How many months of chemo and trastuzumab and how many months of trastuzumab by itself?
Well, there are a few recommended chemotherapy regimens. In Europe, where they did a different trial, the ALTO trial, the HERA trial, I'm sorry. In the HERA trial, the trastuzumab was given after chemotherapy. In the United States, all of our chemotherapy was given concomitantly with trastuzumab. So in the United States, we feel that concomitant trastuzumab and chemotherapy should be given. So in the United States, there are 2 or 3 recommended regimens. One would be adriamycin and Cytoxan without trastuzumab, followed by a taxane, either Taxol paclitaxel, or docetaxel, which is called Taxotere. And so that's a sequential approach where during the adriamycin part of the regimen, trastuzumab is withheld because both of those regimens can cause heart toxicity. Adriamycin worse than trastuzumab, but you put them together and there is a 4% risk of congestive heart failure. So one set of options would be to give adriamycin cytoxan followed by a taxane with trastuzumab. And the other option would be to not give adriamycin, an anthracycline, and give Taxotere, carboplatin, and Herceptin. And there's another regimen, Taxotere, cytoxan, Herceptin, that is also under study, but is not approved as an approved regimen for treatment of HER2 positive early stage breast cancer.
So a woman should really expect about a year of treatment, does that sound correct?
It will be a year of treatment during which time they will get a certain length of chemotherapy. For instance, if one uses the TCH regimen without adriamycin, that regimen will last 18 weeks. If one uses adriamycin and cytoxan every 2 weeks, followed by Taxotere every 3 weeks, that would be 20 weeks of therapy. And if one uses adriamycin, cytoxan, followed by Taxol or paclitaxel, that could be a 6-month chemotherapy regimen. And then one gives Herceptin to a total of 1 year of Herceptin. The way we calculate it out is a patient gets 52 full weeks of Herceptin, some of it with chemotherapy, some of it alone.
I see. So let's take the TCH regimen, which is gaining more popularity. What are some of the side effects during the chemotherapy period?
During chemotherapy, docetaxel has to have steroid premedication. So steroids are given for 3 days. So you have to superimpose some steroid toxicity. And steroids can cause puffiness of the face over a 6-month course of treatment. But it's necessary to prevent allergic reactions from Taxotere, and also necessary to prevent fluid retention, which is a complication of Taxotere or docetaxel therapy. There can be sores in the mouth. It can lead to a significant drop in the white count, so we always recommend using pegfilgrastim or Neulasta the day after TCH in order to prevent the development of infection. Nausea and vomiting is almost a thing of the past because of the very good anti-nausea drugs that we have. Hair loss is definite. Some women develop diarrhea. With docetaxel, there can be nail changes where women can actually lose their nails. They grow back, but it's not something that women relish the thought of. What I generally recommend is icing the fingers and the toes of patients who are receiving Taxotere, not just in the TCH regimen, but whenever Taxotere is given.
When should they ice? When they go home? So they should have their hands and feet in ice. And you have that in your infusion centers?
We do have it available. I don't know. I haven't been asking whether the nurses have routinely been doing it. I know in Israel they actually came up with mittens and gloves, iced mittens and gloves that they use for docetaxel administration. The other troubling side effect of docetaxel is that it can cause tearing of the eyes. That's because it scleroses down the tear ducts, and sometimes ophthalmologists have got to do a little snip procedure where they make a cut in the tear ducts or put in little tubes, because women don't want to walk around crying all the time. Diarrhea is a potential side effect as well.
How do you handle the hair loss? Because that is so important for women.
There's no real way to handle the hair loss. I mean, there are good wigs. There are other hair devices that women have become very, very creative with. There was something called cold caps in the United States about 15, 20 years ago, which we did use. And they actually do work with certain drugs. They don't work with adriamycin. There was a paper published, presented in San Antonio a few months ago where they looked at cold caps, and they found that it was 80% effective with the taxanes, but not effective with adriamycin.
When does the hair loss occur, and when does it recover?
Well, with adriamycin, you can set your clock on it. It will occur 17 days after you give the adriamycin. So women come in, let's say 2 weeks after their chemo, and say, I'm not going to lose my hair. And 2 days later, it's all gone. It's a little more variable without adriamycin, perhaps a little longer. But usually by the second course of treatment, most women have lost their hair.
And when does it begin to recover?
After completion of chemotherapy. In women getting adriamycin, Cytoxan followed by Taxol, sometimes people start to recognize that they actually have some hair regrowth during the Taxol part of their therapy.
I see. Can a woman work during this chemotherapy time?
Almost always, if they wish. I think that the thing that was most debilitating in the past was the problem of nausea and vomiting, and that's more or less a thing of the past. So most of our women who wish to work do work.
What happens to menstruation in women that are not menopausal yet?
Most of the time, chemotherapy will shut off menses, and whether the menses will recover or not depends on the age of the woman. Most of the time, women under the age of 35 will regain their menses. Between 35 and 40, probably 75% will regain their menses. Over 40, most won't regain menses.
What are your recommendations in terms of fertility preservation for women that do wish to become pregnant later on?
Well, many of our women are really adamant about this, and most of them go for in vitro preservation of eggs or fertilized embryos.
How long does that take?
It doesn't take very long. It takes probably 2 to 4 weeks.
So if a woman has had surgery and they come to see you, you do give them that time period to go to see. So that can be done before you begin the treatment?
Yes.
I see. That's very nice. Okay. What about, how do you handle support from family? What is your recommendations to husbands, boyfriends, brothers, children?
Well, they've just got to be understanding that there are going to be times when the patient is not going to feel well physically, and there are going to be times when they're not going to feel well emotionally because they're going through very turbulent times, taking toxic chemicals. So they need a lot of emotional support and love.
Now you mentioned that the Herceptin potentially can be toxic to the heart. During the course of the year, how do you make sure that the heart is doing okay? Is there a certain test you check?
We generally do echocardiograms at the conclusion of chemotherapy, and then probably midway into the Herceptin alone part, and then after completion of Herceptin. and probably once more a year after.
Mhm. And generally speaking, what do you tell your patients regarding the odds of cure of either lymph node positive or lymph node negative HER2 positive breast cancer?
Well, it's a spectrum. You know, it goes from negative nodes and patients with small tumors. The likelihood of cure is probably well into the 90s. And of course, it goes down significantly with larger numbers of nodes involved. But still, I think we should be able to cure probably 70% of all patients who are HER2 positive. That's even taking the patients with 8 and 10 positive nodes, lumping them with the patients who have very small tumors. If you look at the studies that have been done, about 85% of women that were eligible for entry into the studies, and most of those had positive nodes, and most of them had tumors greater than a centimeter in size. About 85% of those were disease-free at about 5 years.
I see. And I think more than anything else, patients want from us is hope. How do you give your patients hope when you speak to them?
Well, I basically tell them that HER2 positive disease in the past used to be the bad girl of breast cancer, and now that we have so-called triple negative disease, that's the new bad girl. And now I tell them, you know, it's almost good to be HER2 positive because we have so many tools in our armamentarium. We have trastuzumab and we have lapatinib. And coming right down the pike very shortly is pertuzumab, which is another drug. And behind that we have TDM1. And behind that we have a host of other drugs that are showing tremendous promise in HER2 positive disease. So being HER2 positive is actually kind of a good thing because it's one of those types of breast cancer where we've identified a target and we've identified many different ways of hitting that target. And you're going to see increasingly permutations and combinations of anti-HER2 drugs that are going to lead to increases in curability. And I would predict, actually, that we're no more than a decade, maximum 2 decades, away from a time when HER2 positive disease, early HER2 positive disease, will be curable without classical chemotherapy.
Well, thank you so much. Thank you for watching. We hope this has been educational.